So, without further ado, what I'm going to do is introduce the next session. And I think this is a very important session for us to actually listen to. And unfortunately, the speaker, Dr. Evan Adams, wasn't able to be here. But this is all about First Nations Health Authority update. And I think many of you know that we are the only province in Canada to have a First Nations Health Authority, which is a quite impressive feat, and that First Nations make up one of our most disadvantaged populations, not only because they're rural and remote, but because of their history in residential schools and their mistrust appropriately of much of what we've done. Evan Adams is a Coast Salish physician and actor, actually from the Silliman Band, and he grew up outside of Powell River. He's quite accomplished and actually was one of the directors of the Indigenous Physicians Association at UBC and the Indigenous Peoples Association Council, which is of Canada, which is a large group of physicians from First Nations, Métis, and Inuit. He actually is trained as a general practitioner and has a Master's of Health Administration from Johns Hopkins, and also trained both in Calgary and at UBC. He's a very accomplished physician, but also a very accomplished leader, and is the first Chief Executive Officer and Chief Medical Officer of the First Nations Health Authority. And so we've been working with him on a number of projects, and we thought that you should hear what he has to say about First Nations Health Authority. And so this is our first head style talk.
Hi there, my name is Dr. Evan Adams, and I'm the Chief Medical Officer of the First Nations Health Authority here in Vancouver, British Columbia. I'm really happy to talk to you today for several minutes about the idea of Aboriginal and First Nations health as it pertains to the topic kidney health. And I think today will be a little bit different than the other presenters. And so if you just bear with me for the next 20 minutes or so, to talk about some other kinds of concepts of health and wellness. So I'm from Slyman First Nation, which is near the town of Powell River, and I grew up with a very traditional father and a mother who went to residential school for, for 12 years, because she graduated from grade 12, and she spent the first couple of years of that in a TB hospital. And I'm telling you that because I think it's really important. They're together because they came from different worlds. He was a traditional person who really knew his territory. She could function well in a modern society. She could read and write. And my mother really didn't even know how to cook a fish when they married, even though we're people of the salmon. And my dad, English is a second language, and he doesn't read or write very well at all. And I think that, if you go to the next slide, that kind of two solitudes, the idea of Indigenous peoples living within dominant cultures, is one that's actually very well noted by, say, the United Nations, which recognizes about 80 Indigenous cultures around the world living in varying countries, from the United States, Australia, in Polynesia, parts of Asia, actually on every continent except Antarctica, there are Indigenous peoples who've been impacted by waves of migration. And migration is not a bad word. We're human beings, we have legs, we're not barnacles, we move around, and certainly every single person who's out there has migrated to a place of other, to a place where there's a different culture than the one that they were born into, and that's a very natural process. But for Indigenous peoples in Canada, and Canada has Indigenous roots, there were millions of Indigenous people here before the arrival of Christopher Columbus, and those Indigenous peoples used to own everything, and now they own hardly anything, and Indigenous peoples in Canada have the worst health of any ethnic group in the country. And that is partly not by chance, it's partly by their cultural and historical inheritance. So we'll talk about that. The picture on the slide is actually of an island in my territory. It's called Ayus, Savory Island in English. The island, if you cut it along its long spine, one half has been cut into little tiny pieces of real estate, postage-sized, some of the most expensive in the country and thus in the world. And the other side, which is still in the possession of indigenous peoples, of my peoples, of the Tla'amin, part of the Coast Salish speaking tribes, is completely undeveloped. There isn't even a place to pitch a tent, or there isn't even a tap or an outhouse. And those two solitudes exist side by side. And to me, they're very representative of Canada, of Indigenous Canadians and other Canadians living in their two solitudes, when really, on this island, they could be living together and saying, we share a water table, we share this beautiful ocean, we share this land. How do we get along? And if we had a hospital or a clinic, if we had a doctor, or say a kidney doctor or a transplant service, which side of the island would that clinic or service be on? And who would go there? Certainly it is meant to be for all of us here who live on this island, but that maybe isn't necessarily quite the case. And certainly in a perfect world, those two sides of the island would coexist harmoniously with respect and honor between them, not just merely tolerating each other, or even worse, fighting over resources. Let's go to the next slide. This is an elder from my community. She was a very wonderful woman, but she reminded me of many things, or this photo reminds me of many things. I asked her when I was little, I said, what was it like before residential school? She hadn't gone to residential school. What did you do before there was a school system? And she said, and I'm saying this word perfect, she said, there was nothing to do, we had nothing to do but help the people. Her education was about going out and doing whatever needed doing. She would go and draw water for a family. She would look after children, who were smaller than her. Sometimes she would cook, or she would clean, or she would be cutting wood. And sometimes she had very complicated things to look after, even though she was a little girl. Whatever needed doing. And I remember that idea of service, whatever needed doing, as I trained as a doctor, and other doctors, or other doctors, it was me. I remember describing to an elder once, saying, "Oh, can you imagine I was in Emerge tonight, and I had a stroke and a heart attack, and I had a motor vehicle accident with 3 victims that were lying there and needed to be assessed, and then this little old lady says, 'Can you get me a glass of water?' Can you imagine I was so busy and important, and she asked me to get her some water?" And the elder said, "Oh, maybe she thought you were there to help." And it really was a reminder to me that we must do whatever needs doing. And so for physicians, if we're not serving one part of the population and we're overly serving another, we really should take feedback and say, I am meant to help everywhere, not just this group over that group. And actually the inequities in health that we can see, and we'll talk about inequities in kidney outcomes, they're actually immoral. We mustn't support a system that favors one type of patient and neglects another. I remember speaking to a minister of health once, and he was saying, are we in charge of this particular population that he didn't really quite like? And I said, yes, sir, we serve all our populations. Absolutely, we serve them all. We don't leave out the ones that you don't like. That's what I wanted to say. I didn't say that. But this elder reminded me of the idea of service, the idea of inclusion, and doing what's sensible. So we go to the next slide. Here in British Columbia, the First Nations have become equal partners in their healthcare delivery, in that, as many of you may or may not know, the lion's share of health work belongs to the provinces. The federal government plays a smaller role. For First Nations people, we used to be we were considered federal subjects, and thus we received special federal funding to receive health services. And often we were excluded from provincial services. The provincial services saying, you're covered by federal services, so go somewhere else. And in the last many, many years, about the last 10 years or so, First Nations have been saying, we want to participate in our own healthcare system and not just be passive recipients. And at some of those tables, we would literally hear, "We don't think you have the capacity to look after yourselves. We don't see the capacity for you to look after yourselves." And that really kind of galvanized us, and we said, that's ridiculous. Of course we can, because like most patients, we already are looking after ourselves, and the services that we that we ask for, say kidney-related services, are adjuncts. We only come to them at special times in our lives. So looking after ourselves is part of the patient voice. They're already accomplishing it. Sometimes they need help, and that's why we're here. So on this slide, and you can see Chief Douglas White III talking about the health and wellness of my people depends on how well I work with each and every one of you in this room. We shouldn't be asking, say, First Nations clients to look after themselves or asking an external entity to do that. We actually all do that together. We look after each other. Part of our job here, as those of you who are service providers, is we look after others and all others, not just a certain portion. So here, the chief is acknowledging the role of others and the role of partnerships and the role of teams and looking after his cohort and his peoples. And we'll go to the next slide. And the next slide, a shared commitment. These little symbols, I know it's hard to see on the slide, but they represent a number of formal agreements between the federal government, the provincial government, and First Nations governance to look after First Nations people. Mainly, we want to address the inequities or the unequalness in health outcomes between First Nations people and other British Columbians. But we've signed agreements that we will do that. And so when I meet with other stakeholders, let's say people who look after patients with issues with their kidneys, I say to them, can you help Aboriginal and First Nations people? They're worthy and deserving of our help. In fact, they have a right to have help. In fact, they're asking for and even demanding equality in outcomes, because equality in outcomes is equality. So how are we doing as far as equality in outcomes? The next slide is really just showing that there are many structures in place around governance. Aboriginal people have, First Nations people have chiefs. First Nations people have health organizations like my health organization, the First Nations Health Authority. We have workers on the ground who are represented by various health worker organizations like the First Nations Health Directors Association, which is one of the icons here. And we have accountabilities to our First Nations governance. We work for the people as opposed to, say, the provincial government or a big boss doctor. We work for the people. And let's go to the next slide. And we're not without resources. In fact, First Nations have 203 communities, and those communities have infrastructures. They have buildings that as well that help them with their health and well-being. We have actually 164 community health facilities, places where healthcare workers can and do work. And those health structures are actually largely invisible to most of the province's healthcare workers, and that's unfortunate. There are 6 provincial health authorities, and in fact the First Nations Health Authority is considered the 7th health authority, though we're a slightly different structure, a slightly different animal than a regional health authority or the PHSA. But we do provide service like the other health authorities. And go to the next slide. So how are we doing as far as kidney health? First Nations peoples in BC are at higher risk of kidney disease, and this is true in the majority, I say, in my opinion, in the majority of health entities. We see a higher burden of illness. Part of this is related to our higher burden of illness in many other areas. So if we're not as strong, we tend to get more diseases, and so we start this vicious cycle of vulnerability and poor health, leading to vulnerability and poorer health, and down the line. So it's not uncommon for us to see the poorest, most vulnerable section of society, Aboriginal people, with the highest burden of illness, and in this case, kidney disease. And this kidney disease is very much related to other health conditions. And so for us, when we look at kidney health, we would say, well, let's look at the whole health of the person, because certainly there's probably things that we can do to help with their kidney health that's actually protective of their overall health. First Nations people also have a history of presenting late for whatever reason. And there are many, many barriers of health. They haven't really been truly confirmed by a lot of research, but we can guess using our best knowledge. We know, for instance, issues like how geographically close is the service to this First Nations community or these individuals, how socially isolated are the Aboriginal individuals or patients. Do they feel like this service is a service meant for them and where they feel welcome? Historically, how have they done in the care of caregivers who are not part of their culture? Like, do they have previous experiences, colonial experiences, disrespectful experiences, experiences where they feel belittled or blamed or stigmatized for the health conditions that they have, et cetera, et cetera. So there's a whole constellation of barriers that need to be identified for the Aboriginal client that need to be identified and then knocked down. And I personally have a list of about 22 pieces. One of the largest that relate to you as caregivers is probably around cultural competence. Cultural competence or cultural safety or cultural humility is an institutional response to someone from a different culture whereby we serve them in a way, in a manner that's recognizable to them. So for instance, in Canada, where we have such a multicultural, pluralistic success story, physicians are meant to serve all different kinds of Canadians, not just ones from, say, a European type culture. They can reach out and provide effective service, bring someone in and say, I'm meant to be helpful to you. You can trust me to help you do the best by you. We know, this is the fourth bullet, that Aboriginal children are less likely to receive kidney transplants compared to white children, and we need to control for those external factors that are part of Aboriginal lives and see which of those are related to the caregiver. There is the possibility, we know this from looking at American studies, looking at African American populations and other ethnicities in the US, that some caregiver bias can prevent patients of color from receiving the standard of care every single time compared to other Americans from other ethnicities. Meaning that, just to put it really bluntly, racism can exist within a caregiver. They look at a client and they say, this patient won't possibly at all be able to meet the requirements for my care, so I will give them some substandard care. If, let's say, I'm going to give them a kidney, I have to decide if I'm going to give them a kidney, and I think they don't look like someone who could look after a kidney, then we may be biased against actually giving them that. And so this statistic of Aboriginal children being less likely to receive kidney transplant compared to white children really needs to be dissected, so we provide care equally as clinicians and we eliminate clinician bias. And that means having better quality data. It means having the ability to analyze that data and have the ability to quantify inequities and make recommendations. Let's go to the next slide. So, the number of kidney patients with diabetes have remained constant over time, and this slide shows that 50% of the time kidney disease patients in BC First Nations also have diabetes, which means that 50% of kidney disease patients do not have diabetes. That's quite a large burden of kidney disease that's non-diabetic in nature. And what is the meaning of that? What is of this statistic? And like many statistics, it raises more questions than it answers, and it asks us for better quality research and better quality data to explain the reason for that. The next slide. So the First Nations Health Authority, in speaking to its constituents, and we've spoken to tens of thousands of First Nations clients, we've asked them, what do you need for health? What do you need from your health system? And we have heard very clearly from them, almost to a person, that they wish to have a holistic approach to health, that to them health is not just physical health, that the mind, body, and spirit for them, for us, is very well known, well connected, and that's what we learned as children. And so our spirit and our mind and our feelings need to be well, not just with our bodies. And if